Welcome to the launch of Leadership Lessons in Troubled Times. This series of virtual fireside chats is brought to you by the Schulich Executive Education Center, or SEEC. My name is Robert Lin. I am Associate Director at SEEC and will be moderator for today's session. Today's topic is Leadership Lessons from COVID-19. Joining me for today's 30-minute fireside chat are Dr. Michael Gardam and Alan Middleton. Dr. Gardam is Chief of Staff at Humber River Hospital in Toronto. He will be interviewed by Alan Middleton, SEEC's Executive Director. There will be a 15-minute Q&A session at the end of the fireside chat. Attendees can submit questions using the chat function on your computer, and we will read out as many of the questions as time permits. We are recording the session so that we can share today's fireside chat with those who are unable to attend this afternoon's live session. Now, let's get started. I would like to hand over to SEEC's Alan Middleton. Thank you.
Thank you, Robert, and hello to everybody out there. I hope everybody's isolating, cleaning hands, and doing everything else. We're very lucky. You probably all by now know Michael Gardam's name. If he wasn't already famous enough when he was in his infectious disease portfolio at UHN, and now in his senior level role at Humber River, he's been in the media a lot as the expert to go to about the COVID-19. So I'm going to start talking a little bit about Michael's view on COVID, but then move to the topic, which is leadership lessons. So Michael, can you give us a bit of an update on how you see things going, Canada and Toronto region in particular?
Yeah, for sure. Thanks for having me on the call. I think that to me, we've actually done a pretty good job in Canada. Some provinces have done a bit better than others, as you may have heard in the media, but overall in Canada, we've done quite well. And all of the physical distancing we've been doing over the last month or so has put us in a position where this is the peak of the surge right now. And so those of us working in hospitals, I keep getting asked, how overwhelmed are we? And the answer is we're not. We've got a lot of empty beds. All hospitals made capacity in our ICUs, and by and large, we have space there as well. So we planned for the worst, and we've been very pleasantly rewarded with the hard work all Canadians have done with respect to physical distancing. So we're in much better shape than our models suggested would be the worst case scenario. We're not going to be New York City. We're not going to be Northern Italy. And now it's easy to shut stuff down. Now the hard part is starting stuff up again. And that's something that's occupying probably most people's time, is trying to figure out what we do next.
Yeah. You talk a little bit about your role as senior executive at Humber River and how you've managed the staff relations through this crisis, because there is no doubt, despite your wonderful optimism, which we love, the hospitals and the care homes really have been the front lines on this.
Yeah, this has been really, really challenging. In the healthcare sector, right? Not only are people impacted by the physical distancing at home and the insanity of buying groceries these days and all things like that, but then they go to a work environment where they're surrounded by people who are sick, who may have COVID-19. So there's that added personal fear element, not only for themselves, but for their family as well. A number of our staff worrying about bringing it home to their families, for example. And then you can take that up and even a notch further if you're one of the groups who works in higher risk areas. So for example, if you're an anesthetist, you spend your career doing what we call high risk procedures. So you're even more likely to get exposed if we don't protect you properly. So all of that plays into it. And certainly for the last 6 weeks or so, we've gone through waves of basically fear and trying to manage that as best as possible. And I have a little bit of an advantage over probably other medical leaders in that this is actually what I used to do for a living. So I have a lot of background in this, which is, believe me, come in very handy. So obviously, communicating out what's going on and being very transparent. I mean, if we're running out of PPE, we say we're running out of PPE, not holding anything back, being honest when we don't know things. But also it's very much a two-way street. So what all medical leaders have experienced is a number of people coming forward saying they don't feel safe, they don't feel protected. They're hearing from other colleagues that we should do it differently. All of that's going on very rapidly. And so I need to communicate out, but I also need to listen to you. And where possible, I need to work with you to help you protect yourself. And so that may mean, you know, spending a lot of time with different groups as they bring up ideas and helping them try to get to where they need to get to so that they actually feel safe. Mm-hmm. You know, people need to feel supported. They need to know that you have their back, that this is not just window dressing. So it's pretty, I'd say the last 6 weeks have been pretty tiring because it's tiring to be around people who are frightened all day. Because their fear rubs off on you and then you get frightened, and then you might make that group feel better, but then the next group comes forward and they're frightened. I definitely am at a point now where I kind of feel tired all the time. So I'm looking forward to this calming down a little bit at this point.
Absolutely. Yeah, you're touching on something. Actually, we've got already one of the questions. The question came from John Buckingham, which is the roles of formal hierarchic leadership fairly straightforward in a crisis, but what he asks about is the growth of the role of informal leadership, which may or may not be senior. How do you see that operating in your experience?
You know, it's funny, in my career I've talked about informal leadership a lot, you know, and I said how important it is, but never have I seen it exemplified so much as during this pandemic. You know, we've got some medical leaders who are not in formal leadership roles who have really stepped up, volunteered their time. I mean, we have a group of doctors here led by anesthesia who have volunteered to work in our ICU. That's a very high risk exposure kind of situation if people are not properly protected. And so we've had doctors like that popping up and really leading the way, and they're so critical in leading their own group because people are more likely to trust someone who's like them rather than me, right? And so that's been absolutely instrumental in us being able to muddle our way through this. The way I describe leading people during this time, it's like trying to hold a handful of little tiny Jell-O cubes, and they're constantly squeezing out of your fingers, and you're trying to just keep it together at a time when people are really frightened. And I get it. I get why they're frightened. They're not exaggerating it. And so those informal leaders really stepped up to help keep the Jell-O intact, so to speak.
Yeah. And you're saying a lot of people just stepped up. How do you encourage that as a senior leader? Because that's good news.
Yeah, no, it is. And you know, my leadership philosophy has always been one of sort of frontline ownership, where I have a sense of where we need to get to, but I'm not the expert in your area. I don't know what it is that you do, and I'm not experiencing the risks that you're experiencing. And so who the hell am I to tell you, you know what, you're fine, don't worry about it. That doesn't go over well with people. So you really need to get into the conversations, and where I feel that we're going too far, I will, because of my background, I will push back in a gentle way. But by and large, they're the experts in what they do. And as long as what they're saying isn't dangerous and it's got sound logic behind it, I'm going to support them. And so when people hear that, you tend to get more of those people showing up because they feel like they're being listened to. And I've learned through enough outbreaks of SARS and Ebola and H1N1 that if people feel not listened to, you lose them. They start doing their own thing.
Absolutely. Absolutely. How do you reward that practice for people? Because as you say, what you don't want is lots of people heading in different directions, but you want those ideas and that commitment.
Yeah, it is tricky because, again, people can go off too far in directions. I had a call yesterday where I had to, gently push back against a group of doctors saying, I actually don't support the direction you're going because I think it's going too far, versus other things as well, So you're encouraging, but at the same time, you can't always agree with everybody, and you do need to push back on occasion, but at least I'm trying to do it not from an emotional or a personal perspective, but from the this is what the data suggests, and this is where I think we need to go, or this is why I'm not able to agree with you. I mean, one of our issues, a big issue has been for us, has been personal protective equipment supply.
Yeah.
And from the very beginning, we would love to mask everything that moved in the hospital if we possibly could, but we didn't have enough masks. And I needed to reserve those for the people, for our healthcare workers.
Right.
Because I felt there's bigger benefit for them wearing it than a visitor who's going to come in once and then throw it away. So working through that has been really difficult, but it's meant to be a two-way conversation.
Yeah. We're getting a lot of questions in, but I want to ask one more before we go to the group, which is, so far, based on your experience, what would you take away for the future in ways that you might think different in what you prepare for this? You know, we've talked about contingency planning. You went through SARS. What should we have done a little bit different as leaders?
Yeah, it's been very frustrating to watch that because the amount of planning that occurred after SARS was unbelievable. I mean, I was involved in every bloody government committee going, right, on pandemic planning and creating stockpiles and HR workforce things and developing ethical frameworks for patient triage. And we did all that work. And I think, you know, what happened in Canada, interestingly enough, is when the pandemic came in 2009, it was kind of a meh, really was not a big, I mean, it was a pandemic from an epidemiologic definition, but it was actually less serious than a regular flu season. So there was a lot of concern. I remember I did like 150 media interviews for H1N1, and it was like a lot of concern. And then when the numbers came out, people are like, what the hell? Like, this wasn't a big deal. And I really feel the gas was out of the tank. Like, all the pandemic stuff stopped after that. It was like, which is illogical if you think about it. Just because that one was mild doesn't mean the next one's going to be mild. And to me, one of the biggest learning points of all of that was we argued for years we need domestic supplies of personal protective equipment, of drugs, of ventilators, of medical equipment, and we didn't do it. And we had been talking about that since 2003. We had a stockpile at least, but then we didn't maintain it, and the pieces of equipment in there expired. And then, as you heard in the media, we threw them out. And to me, that's very frustrating because, you know, globalization, I think, is a lovely thing unless the entire world is in trouble. And when it's in trouble, you're screwed. Canada is not big enough to throw its weight around to get what it needs. Even the, you know, most powerful country in the world is screwed right now, worse than us. And so having that domestic supply of all of those things is incredibly important. Yes, it's going to cost more money, but you know, preparedness does. Insurance costs money.
One of the questions coming up is something I experienced back through 9/11, which is how the different groups, whether it's government or security or healthcare, were on different communication systems, and there wasn't a good integration of activity. Have we improved? From your experience, I mean, is there sharing of ideas across hospitals or public health care into the hospital system? And
in some ways we have improved. If I think back to SARS, you know, I found out about SARS because one of my colleagues happened to call me and ask me questions about it. I'm like, what the hell are you talking about? Don't have that problem anymore. Our problem now is that the number of communiques coming from various organizations is so overwhelming. You can't read them all, and they don't always agree with each other. But let's take that up a notch. So you can have communique from within government, the broad government, where it's coming from the Ministry of Health, it's coming from the Ministry of Long-Term Care, it may be coming from the local LIN, it may be coming from public health. It's overwhelming. But let's actually take that up a notch when you realize that nowadays everybody's interconnected with everybody in the world. So one of the challenges I had at the beginning of this, which was, you know, to hell with Ontario's guidance. I've just spoken to a colleague in Hong Kong who says we should do this. And everybody's doing that. And papers are being shared back and forth. So you have this very informal communication structure, which is overwhelming the formal one. And the formal one is overwhelming with so many messages coming from so many different places that, like, I sort of joke that we're trying to stop the pandemic by, creating PDF documents. If we can create so many PDF documents, the virus will stop.
Yes.
And it's I actually think back fondly to the days of SARS, which was once the Ministry of Health got its act together, there was one line of communication, and that's all you got.
Yeah.
And we didn't have Twitter, we didn't have all of the social media that we have nowadays, and so it was much easier to communicate. And this has been infinitely more complex to try to handle.
Yeah, especially when you've got different levels of government. I've got a question here from Dean Colliver. It's a bit of a long, so apologies. In managing individual leadership resources within an organization, which capacity should be prioritized over this time? Collected information or empathy? Now, he's asking a question about which should be kind of emphasized. What do you think?
Yeah. I have to say that you can't overcall the importance of empathy, especially when dealing with any frontline provider who's kind of in the line of fire. And I'm just not talking healthcare. I mean, there are people out there that many people, if they still have jobs, who are in service industries, who by their very nature cannot physically distance. I mean, we can do what we can, and there's some great ideas putting plexiglass and all sorts of things, but by and large, these front-facing jobs where you're interacting with people all day long are incredibly stressful right now. And so I have to think, and then I talk about my healthcare workers, if I didn't have empathy for the situation that they're in, and they're worrying about personal protective equipment and bringing this home to their kids, and whether, they just saw a 40-year-old die in the ICU, and are they going to be the next 40-year-old who dies in the ICU? I think if there's no empathy, I don't know how you'd be able to lead them. I think they would leave you. I think they would go off on their own, right? So, I mean, I've really spent the last 6 weeks, I sort of joke, I feel like a den mother. I just constantly worry about our staff, and do we have enough stuff for them? Because they're in a very tough situation.
In view to the question, I think both are equally important. You have to go through rehearsals and make sure you've got the right systems. But the application of those systems is all about how people feel about each other. Absolutely.
Yeah.
Jenny Williams has asked a politically risky question. So I
love those.
Would you say that the leadership was the difference between the COVID situation in Canada and the United States?
Oh yeah, I don't even have to blink at that one. Absolutely. I find the United States situation, I find it incredibly sad, to be honest with you, that you have a country which is a world leader in so many different ways. And I think, there'll be Harvard Business Reviews written about this for the next century, about how leadership plays a role. It's not like they didn't have the resources or have the testing capability or have the manufacturers of personal protective equipment, or they make ventilators in the United States. They do all of that stuff. And yet they were caught very, very flat-footed. And it's interesting, we wondered about that back in 2003 with SARS. If SARS would have happened in, let's say, New York City, what would that have looked like, given the mix of private and public hospitals? And it's so much more fragmented, the American healthcare system, than it is in Canada. So part of this might be that's the US system, and it is very decentralized and very fragmented, which led to some of this. But I also have to believe that, in Canada, very fortunately, our politics have been put aside for a while.
Yeah.
You start to feel the knives kind of coming out now, but by and large been put aside.
No, absolutely.
All speaking with one voice, all wanting to do the right thing, and that is definitely not the case in the US.
Yeah, very much so, except for some governors who seem to have taken it on. I have to go back to a healthcare question because I've got a whole bunch here. putting you on the spot from your expertise. This one particularly is from Joanna Tommy. How quickly do you foresee a vaccine for COVID coming out? And how much testing do you think is needed? It's interesting, our China office sent us that the Chinese have announced they've had in testing and they've had early positive results with a vaccine. Now, that's going to get everybody excited, but what's the reality here?
Yeah, I mean, it sounds like, I mean, there's literally, I think when I last read yesterday, it was over 70 different candidate vaccines that have been worked on, and they found very quickly the target they want to make the vaccine against. So that hasn't been the difficult part. And I think that some of the work that was done on trying to create SARS and MERS vaccines in the past already gave people some background on where to look. Here's the catch though, and you can't really speed this up. Once you've got your candidate vaccine, you have to go through phase 1, phase 2, and phase 3 trials. And there's really no easy way of rushing that. The first thing you need to do is show that you can give different doses and people don't develop weird and wonderful illnesses from your vaccine. Then you need to figure out, the different dosing levels to see which is giving you the best response. Then you need to be giving it to people to see if it actually works. And all of that takes months. And that's the part that Donald Trump got confused about, because he kept hearing we could have a vaccine tomorrow.
Yeah.
Yeah, but you don't know if it works tomorrow. You've got to actually take it through the trials. And that's a minimum, people are saying a minimum of a year to 18 months. And there is some importance to this, because there have been vaccines in history that have made people sick.
Mm.
So in 1976, when the US rolled out the swine flu vaccine, there were some significant side effects from that. There have been vaccines for children against a virus called RSV, which actually made the children worse. There have been measles vaccine, which actually made children sicker. Now, none of those are the ones that we're currently using, but just to give you a sense that when you're trying vaccines, they're not all going to be perfect. And some of them you need to find out very quickly if there's a problem. Stop that and then try another one. So we're stuck. We're not going to have it as quickly as we'd like.
A couple of others on a similar topic, Michael. Again, I warn you, putting you a bit on the spot here. Sorry about that. How quickly should we go back? And let me contextualize that, which is assume there's no vaccine that's been approved at the stage, but if we pass the peak, what would you advise governments to do on this? Because they'll be under enormous pressure to go back quicker because of the economy, but also pressure from the medical side, rightly, that don't go too fast. How should you judge that?
Yeah, there's a massive tension right now, right, between the keep it shut down and open it up again. And you see this playing out in the media all over the place, especially in the US, where it's been, again, very vocal. We absolutely do need to open up. The question is doing it safely. The way I describe it right now is the way Canada has dealt with COVID-19 has been with a sledgehammer. It's been a very sort of indiscriminate, just isolate everybody and we'll be good. And that worked very well. Mm-hmm. But, that's like treating somebody's cancer by removing everything below their neck. Like it's just way too much. We needed to do it, and we did it. And I'm very happy that we did what we did, but now we need to be much more selective in our control measures. And that comes down to, we need to have widespread testing capacity. If you look to Germany, for example, they've done very well through all of this.
Mm-hmm. Death rate is very low.
They have kept their parks open.
Yeah. They
have not been as aggressive with the physical distancing that we have. And the way they got away with that is they have done hundreds of thousands of COVID-19 tests. Mm. And similar strategy was done in South Korea as well. So to me, our way out of this is stepwise selective loosening of some of the control measures, waiting a few weeks to see if anything is telling us that we're getting into more cases again and we have to slow down. And that has to be accompanied by massive amounts of testing. Yeah. And we're not there yet in Canada, but we're trying to ramp up to get there. Germany had the advantage in that they have a massive biomedical industry in Germany. And so they have the companies right there that are making these things.
Yeah. Just to put some numbers, which I pulled this morning. So of about 135,000 cases in Germany, their death rate is only 3,800 people. So it's one of the lowest in the world. So absolutely.
Yeah, and that really speaks to the fact that, you know, German healthcare is no better than our healthcare, but what it speaks to is that they've tested way more people. Yeah. Way more people.
Yeah, yeah. Question back to leadership styles. Interesting one from, where was I? Jose. Have you seen different reaction to the crisis and leadership within the different generations of management? Boomer, Gen X's, millennials, and, you know, maybe some of the younger the older centennials.
Yeah, absolutely. You know, I have a fairly small sample size, so it's hard to know if it's just individual personalities versus generational. But you know, I will say amongst healthcare workers that those of us who went through SARS seem to be a bit more comfortable with this, because they're comparing this to SARS and they're going, you know, SARS had probably a 20-fold higher mortality rate when all the dust settles than this did, or you know, than this does. So they're a bit more comfortable with it. We have you know, other generations, the older generation, even than that. I've had a number of older doctors just say, you know what, my time here in this field is done. I'm going to retire. And then you have the leaders that are younger, who I think to some degree struggle a lot with this because they haven't experienced something like this before. Or if they did experience something, it was H1N1, which, as I said earlier, really wasn't that scary. Yeah. And so they don't have any sort of collective experience to draw on. And you know, this has been very discombobulating for every person in Canada. There's no doubt. You know, our whole lives have been turned upside down. Add on to that, now you're a healthcare worker, and you might actually be exposed to this multiple times a day, and that level of fear just takes it up even higher. Yeah,
yeah. Last question from me, then I'm going to, because apologies to everybody, but it's a half-hour show. Then back to Robert to close. Other than vaccine and this, what do you wish for out of this whole experience? What's the big wish you have for us for the future in terms of, you know, thinking about our leadership styles and the management of the healthcare system?
Yeah, we definitely need to, I think, have some very definitive, clear leadership on preparing for the next one of these. Yeah. And that's going to involve some unpopular, potentially expensive, maybe they won't be unpopular because people get it now, but potentially, you know, spending a fair bit of money to ensure that we have resources around when we need them next time. I mean, I'm not that old, and I've gone through 4 of these scares already. So it kind of feels like it's probably money well spent. Chances are, before I retire, there's going to be another one of these of, you know, some way, shape, or form. So I think, you know, having people a bit swim against the stream to say globalization is good, don't get me wrong, and we need to have local supply, local manufacturers. We need to become a little bit more self-sufficient. If anything, the last 4 years have shown us is that we can't rely on the United States to protect us. And we've been doing that for 50 years. Yeah. And so I think Canada needs to find its own voice and be able to protect itself for future pandemics.
Thank you, Michael. I'm reminded of, as you can tell by the accent and as you know, British background. And one of the things as a result of the plague in Britain in the 17th century was the whole rebuilding of all the sewer systems, which cost the government a lot of money. But to that stage, you just dumped garbage out on the street. And that, of course, you know, was part of the basis for the plague with rats coming in. So it will require a new look at investment. Michael Gardam.
Yeah, absolutely.
Thank you very much for this. And you are eminently young. So let's hope you don't go through 2 more of these. Robert, back to you.
Thank you very much. I would like to thank everyone for attending today's session. Please feel free to join us at our next Fireside Chat on April 27th at 11 a.m. with Ronnie Miller, President and CEO of Roche Pharma Canada. Ronnie will share his leadership insights from his 20 years as head of Roche Canada in a session entitled View from the Top. In the United States, Roche has already started working on a coronavirus treatment during testing. Thank you again to everyone for attending SEEC's inaugural Fireside Chat, and a special thanks to Dr. Gardam and Alan for a very thought-provoking and timely session on leadership lessons from COVID-19. I look forward to seeing everyone again at a future session. Thank you and have a great afternoon.
Thank you, Michael.
Thank you. Bye-bye.
Thank you.
Bye-bye, everyone.